Dear esteemed colleague, today we are presenting a detailed case of a patient who recently came to our clinic. She arrived to undergo the standard first trimester screening exam, during which a significant increase was clearly detected in nuchal translucency. For this reason, we recommended to the expectant mother that she undergo both a genetic test via amniocentesis and a structural ultrasound exam. The images we are showing you now pertain to the study of the heart performed precisely during the structural scan, in which we observe a normal four-chamber view. In the realm of actual clinical practice, the diagnostic hypothesis of a probable tetralogy of Fallot could only be definitively confirmed and established after visualizing the detailed anatomical section of the heart during the ultrasound examination. Of the three vessels we have just seen and that we will observe in various scans throughout the entire exam, here in this three-vessel view, we can see even more clearly the predominance of the aorta compared to the pulmonary artery. Now we are going to measure the diameter of the latter, and we see that it is about 1 millimeter. And this, in fact, allows us to make a diagnosis of hypoplasia of the pulmonary artery, even if not severe, but rather mild. In this specific scan, once again, we are carefully evaluating the relationship between the isthmus and the ductus. We are observing this across several different scans to confirm what we previously mentioned. So we can see a very clear predominance of the aorta when compared directly to the pulmonary artery. In this section, we can observe the scan where it bifurcates. Now let's perform the Doppler velocimetry of the pulmonary artery. Now, which can be very helpful in clinical cases where tetralogy of Fallot is suspected. Even though in this case it is not increased, partly due to the early gestational age and partly because, as we mentioned, we are dealing with a mild case. In short, mild, so the velocity of the pulmonary artery is not increased. Now, let's carefully observe the left section here, which in the transverse view appears to be quite normal. However, let's now study it in another detailed scan, where the presence of a specific finding is much clearer. Here we have a clear view of an aorta that we define as overriding, specifically because it arises by straddling the ventricular septal defect, which we are now also going to measure quite carefully. And in this specific case, the measurement comes out to be approximately 2 millimeters. For this reason, since we are at a very early stage, this diagnosis is extremely complicated, so the study of the heart must be performed multiple times, also because, thank you, precisely because we are at a very early stage, it is also very complicated to identify any other associated anomalies. We also go on to assess the possible agenesis of the ductus venosus, which, however, will need to be reconfirmed at a more advanced stage, as we can clearly see the pulmonary veins. But instead, we do not clearly see a connection between the left portal branch and the vena cava, and this could indeed suggest an agenesis of the ductus venosus. The cardiac anatomy must be carefully studied and reviewed multiple times, and not only that. In fact, during the pre-structural phase, it is absolutely and fundamentally important for the clinician to reassess not only all the cardiac structures, but also all the other relevant anatomical structures. Among these in particular, we are now looking at the nuchal fold, which at this stage actually falls entirely within the expected normal range Gange, just like the profile, which, as previously mentioned, is also completely normal. All the other described findings have also been thoroughly evaluated and are found to be normal. In any case, despite these results, it is still advisable to recommend the option of amniocentesis to the pregnant woman based on the specific findings observed today. It is important now to clarify a few points. First of all, it must be clearly emphasized and understood that the primary clinical factor that allows us to accurately evaluate the long-term prognosis of tetralogy of Fallot is, depending on the specific clinical presentation of the patient, it is the overall degree of stenosis of the pulmonary artery. In this specific case, we saw that the hypoplasia was not too severe, so we defined it as mild. Secondly, it is necessary to assess how the case should be managed. To begin with the initial steps, A comprehensive genetic test should be strongly recommended for the patient, specifically an amniocentesis with fetal karyotype and CGH array, as it is crucial to keep in mind the fact that this specific heart defect can be found in isolation. But in about 20% of cases, we find it frequently occurring in conjunction with abnormalities in the fetal karyotype, some syndromic conditions, so it is important to investigate from this point of view. Secondly, it is highly recommended to schedule a consultation with both a cardiologist and a pediatric surgeon because by utilizing the detailed ultrasound data we provide, these medical professionals will be able to guide the plan and thoroughly assess the situation. Specifically, they will also be able to evaluate the outcome of this condition after birth and indeed manage the heart defect from that perspective as well. From our point of view, however, it is obviously necessary to consider a very close and regular ultrasound follow-up, or at the very least, a standard ultrasound follow-up. Since we are dealing with a condition that is progressive in nature, it needs to be carefully monitored over a period of time, including from a clinical ultrasound perspective.